Our next speaker is Dr. Kary Woodruff, and she is has a PhD in nutrition, but what's really cool, a master's in sports nutrition. She has a degree in psychology, and she directs the master's program in nutrition and dietetics here at the University of Utah and oversees the sports nutrition track. And she's going to help us understand weight bias in providing weight neutral care in healthcare, which I think, weight is such a big deal. And we're in the middle of an obesity epidemic in our country. So even in Utah, we have some.
Thank you.
Thank you so much.
Well, thanks for having me. So as mentioned, my name's Kary, and I direct our master's program, as mentioned, in nutrition dietetics, which just means that we graduate future dietitians. And this topic is very near and dear to my heart. Let's see. Because I worked for about 10 years as a certified eating disorder dietitian. And I worked with patients, initially athletes with disordered eating and eating disorders. And then eventually my practice became primarily all patients with some form of disordered eating. And I felt a lot of tension because at the time I was a full-time practicing outpatient dietitian at Intermountain Health. I was at Tosh at an orthopedic hospital. And I was part of Intermountain's lead team for the Way to Health program, which is a correlate of the New You program here at the University of Utah. It's a 6 to 12-month weight loss intervention aimed at increasing healthy lifestyle behaviors, decreasing body weight. And I worked with, I'm sure, hundreds of patients to help them to lose weight in what we hope is a meaningful way. And then I would put on my different hat and I'd go to my office and I'd work one-on-one with patients with maybe a clinical eating disorder. And I felt like a lot of times there was this tension between what we were asking our patients to do in the context of weight loss, and then how we're addressing and treating our patients with eating disorders, talking about intuitive eating and all foods fit, no good foods, no bad foods. But then at the same time, weight loss saying, we'll eat more of this and eat less of that. And it just felt like there's a lot of tension there. And so it got me curious and I started asking more questions. And I certainly don't have all the answers, but I'm coming to learn what are some of the better questions that we can be asking with this tension. And my goal for today is to talk about some of the challenges that we see with dieting practices. What are some of the adverse effects of dieting? Because it can be seen as a sort of panacea for health. And we know that's not true, but to recognize what are the potential harms when we're recommending weight loss. And then we'll put in the context of how weight loss is increasing and promotes weight bias and weight stigma. And then my hope is to actually have some practical advice of how do we decrease weight bias, weight stigma in the context of weight management. I'm not anti-weight loss, nor am I someone who, I don't fall on either end of the spectrum. I think there's some middle ground that we can find. Can I ask for a show of hands? Who here works with patients in any form capacity? If a patient, maybe you're not addressing weight loss, but you're working with patients who are trying to lose weight, any form of weight management goals? Okay, just helps me to see where our audience is at. In the first half of my presentation, I'm going to be talking about diets. So I first want to broaden that title to say self-directed diets. And that would be any form of likely short-term approach to try to lose weight. It can include intermittent fasting, Optavia shakes, time-restricted eating, ketogenic diets. Now, certainly many of those approaches are lifestyle behaviors for some of our patients, but for other patients, they're more temporary forms of weight loss. And so to try and disentangle that. And so these are often very alluring, very attractive. FOMO is a common reason, fear of missing out, but lots of individuals are going on diets. About 45 million Americans will go on a diet in any given year. And that's just in 1 year. That doesn't speak to lifetime prevalence. The diet industry is about a $33 billion industry. And they're really, really tempting for why individuals try them. And lots of inducing factors as well. There's certainly media pressures, whether we're talking about social media, more traditional forms of media, and also looking at why they're seen to be so successful. We have confirmation bias, which says that what we see what we confirms what we believe. And so if we see someone losing weight, we think, yes, this diet works. Law of very large numbers. If 200,000 individuals lose weight on the celery juice diet, well, that's in larger context, not many people, but it can seem like it's a lot of people who are losing weight on the celery juice diet. And yes, there is a celery juice diet. But to look at the research, and many of you probably know a lot of these statistics, but I think they're worth mentioning when we think of some of the long-term effects. And if you can't read, sorry for the small type, it says, if I gain 20 pounds, it will give me the motivation I need to stick to my diet. And that speaks to some of the weight cycling that we see, and we'll talk about. And there are adverse health effects we see with diets. There was a recent study that looked at the top 4 most common diets, and they found that 0% met 100% of the RDA, recommended dietary allowance, for any of the 27 nutrients that were examined, in part because they promote such a low calorie intake. It's really hard to meet your nutrient needs on such a low calorie diet. There are psychological effects that we see from dieting practices: increased irritability, depression, fatigue, decreased motivation. And this is certainly not an exhaustive list. And yet I think it's also worth mentioning that last point there. I tried to highlight that in bold, but one of the biggest predictors of future weight gain is dieting. So we know that once someone goes onto a diet, they're significantly more likely to gain weight. And that's not what we want for our patients. So when we look at the research, we see that most individuals are gaining the weight back, and actually up to 2/3 of patients who lose weight are actually going to gain back more weight than what their starting weight was. And again, just speaking to, in what area of medicine will we recommend an intervention that has a high likelihood of increased adverse effects? And it promotes a cycle of what we call weight cycling, of losing weight, gaining weight, and that cycle. And we know that's not what we want either. There's some controversial, some of the research is controversial in that it's not very clear cut, but what we think are some of the adverse effects of weight cycling include increased risk for cardiometabolic harm, increased risk for type 2 diabetes, increased mortality. And again, that's the effects of that losing weight, gaining weight, losing weight, gaining weight versus remaining weight stable. Weight loss isn't easy to maintain either, and actually that's really where the crux, I think, comes in. We have evidence-based practices, which I'll very briefly summarize, for how we can help our patients to lose weight, meaningful weight, meaning 5 to 10% of body weight. We don't have great interventions to help sustain weight loss once it's been lost. And there are a lot of reasons for that. There are a lot of environmental reasons. There are a lot of public health policy type factors that contribute to weight regain. And then also just physiological and biological reasons. The body really fights weight loss and fights that maintenance of having a lower body weight. And there's a whole host of reasons. I have, for my hour-long slides, I go into some of the biological, physiological reasons, but there's a lot that fights against us when we're at a lower body weight. And so when I was in my search of looking at healthy weight loss interventions, this comes from the Cleveland Clinic, and, not to be Dr. Google here, but, if someone's looking at how do I lose weight healthfully, well, this comes up from the Cleveland Clinic, and it says, exercise regularly, eat a variety of unprocessed or minimally processed foods with moderate portions. And I think this is such a disservice to our patients. I think it oversimplifies how hard it is to lose weight, and it certainly doesn't capture how hard it is to maintain weight loss. And it results in our patients feeling like they're not going to be successful, right? Because if it were that easy, then wouldn't everybody be at a healthy weight? And we know that's not the case as we look at just public health, looking at the numbers. And so I think first and foremost, just helping our patients to understand how challenging this is. And when we're having these conversations of, if you want to lose weight, let's talk about it. Let's talk about what are the risks, what are the potential benefits, and what is this going to look like for you and your health? I'd like to introduce some terms here, and these may not be new to you, but we have size oppression. This is the experience of harassment and discrimination for being or for not being a specific weight. Weight stigma are negative weight-related attitudes, behaviors, judgments towards individuals who are at a higher BMI. And then weight discrimination is the unfair or unequal treatment of people because of their weight. Weight stigma and weight bias can be used interchangeably. They're not exactly the same, but for the purpose of this today, we can use them synonymously. And then weight discrimination is that experience of unfair treatment. And I wish I could say we were immune to these concepts in healthcare. Unfortunately, we're not. So first, I'm going to define what we can call the weight normative approach, and this still continues to be the majority approach to weight management in the context of healthcare. And this is more the traditional approach to weight. And what this says is that an individual's weight is the result of their poor dietary choices. It's a proponent that individuals have control over their weight, and so therefore obesity is a matter of personal responsibility. And so the consequences of having these beliefs is that it does perpetuate anti-fat prejudice and weight bias. Now, weight discrimination, and here's where when we look at studies that look at the effects of higher BMI, the effects of being in a higher BMI and adverse outcomes, I really encourage you as you're looking in this literature, if you ever are looking in this literature, to really look at the study methods. And what you'll see is very, very, very few research studies that have examined the effects of being at a higher BMI or being obese have controlled for the experience of weight discrimination. And so if you look independently at someone who experiences weight discrimination, there are significant adverse health effects to that experience. And it's similar with other forms of discrimination. It's considered probably the second or third most prevalent form of discrimination here in the United States. But it does increase allostatic load, that cumulative burden of stress in one's life, which we know significantly decreases mortality. It increases suicidality, psychiatric substance abuse disorders, cardiometabolic health, and other markers of inflammation. And so just irrespective of adiposity, but that experience of weight discrimination increases all of these adverse effects, which we also connect with having increased adiposity. And so unfortunately, we just haven't teased out in the weight loss literature to say, well, someone has, a BMI of 40, their body fat percentage is whatever it may be, and therefore that's causing their increased worsening outcomes in cardiometabolic health. But have we controlled for their experience of weight discrimination? That might be contributing to those adverse effects as well. And it's not to say that there aren't lipotoxic effects of having increased adiposity. It's just when we look at the literature that's saying, here's what having increased fat results in, we haven't done a very good job of controlling for other confounding factors. We also know that experiencing weight discrimination is also much more likely to result in decreased physical activity and poor eating habits in of itself as well. So again, there's a lot that's going on that we're not always recognizing. And then the experience of weight discrimination and experience of weight stigma in healthcare, unfortunately, is very poor, or at least is very high, I should say, resulting in poor outcomes. So in one very large sample of women who have a BMI of greater than 30, I don't use the word obese a lot. I tend to frame it in terms of BMI. But 69% reported experiencing weight bias from physicians, 46% from nurses, 37% by dietitians, 21% by other health professionals. Psychologists tend to attribute greater pathology to patients who are living in a larger body. And that we know that, unfortunately, in a 2020 review found that younger healthcare providers actually tend to exhibit greater weight bias and stigma compared with older healthcare providers. So it doesn't seem to be improving. When we look at the harmful effects of weight stigma, this shows, I think, just a nice pictogram of what's going on. So someone experiences weight stigma and discrimination, that increases their allostatic load, that experience of chronic stress in their lives, that increases cortisol, increases eating, results in weight gain, weight regain, and thus that cycle becomes perpetuated. Now, here's where I get to say, let's not throw out the baby with the bathwater. I'm not anti-weight loss interventions. I think we just have to be very thoughtful with how we're approaching our weight management interventions with our patients. I think there are strategies we can help to increase the healthfulness in our patients, may or may not result in weight loss, but it's more how much of a focus is weight in the context of other factors. So very, very quick summary slide. The intention is not to say what does work in weight management. That would be a separate discussion, but just to highlight that there are evidence-based practices that we know of to help support lower body weight or a decrease in body fat among our patients. Again, recognizing that even a 5 to 10% body weight loss, maybe even 3 to 5% can be clinically meaningful in improving blood pressure, improving blood lipid levels, glucose levels, etc. And so here's just really a summary of what we know to be effective. All of this needs to be individualized. There is no one size fits all approach, but there are ways that we can individualize these components to help support lower body weight. And then the Academy of Nutrition and Dietetics had a really nice article I'd be happy to send out that compared self-directed diets. So the individual who goes on the celery juice diet, who goes on cleanses, juicing, time-restricted eating as a way to lose weight quickly, those self-directed diets, how that increases risk for eating disorders and disordered eating, whereby alternatively promoting evidence-based weight loss interventions that is supervised, ideally provided by a registered dietitian in conjunction with a medical provider's primary care, that we can actually help to increase healthy lifestyle behaviors and increase coping skills, increase behaviors that promote health, potentially some weight loss in the context of being in a larger body weight. And so it's more about how we're approaching these patients versus just looking at the weight. So compared to the weight normative approach, where the focus is on weight, I really love and have really embraced a weight inclusive approach to healthcare. So instead of having the emphasis being on weight and the focus on weight loss, the focus is on what the patient has control over, and that's their health-related behaviors, right? So how do we help our patients to increase their intake of fruits and vegetables and whole grains when they have access to these foods? Certainly access is a big point that needs to be addressed, denounces weight stigma, and recognizes that there are so many policy and environmental factors, as well as genetic factors, that contribute to body weight and body size that are very much out of our patients' control. So weight inclusive care is an assumption that everybody is capable of pursuing health and health and well-being independent of weight, given access to non-stigmatizing health care. So there are some commonalities with the weight normative approach. Certainly for individuals who focus on weight, they're still recommending some of the same behaviors of healthy eating behavior, stress management, sleep, all of the lifestyle behaviors that we know to promote health. And so there is that overlap between weight inclusive care and weight normative care. The difference is on the importance and emphasis placed on weight. So is the patient walking into the clinic, the first thing they see is the scale, they're being weighed, and they're talk about, well, how much weight did you lose this week? Versus the patient comes into the office, they may or may not be weighed. They come into the provider's office and they talk about, okay, well, what worked this week? What didn't work? How were your eating behaviors this week? And so focusing more on the behaviors and having not having a focus on the weight. It is not an assumption that everyone is healthy at every size. And I'll talk quickly about the health at every size approach. But it doesn't propose that everybody is healthy at every weight, nor is it anti-weight loss. And so I'll talk about some of those nuances. Looking at alternative approaches that also provide a more weight inclusive approach. Can I see raise of hands? Has anyone here heard of the health at every size approach? Okay, so there are some individuals. HAES is a shortened term, HAES. So I do not identify as a HAES-informed provider, but there are many medical, dietitian, other healthcare providers who do identify as health at every size informed providers. And so to understand what that means, they promote weight inclusivity, which respects diversity in body shape and size, and reject idealizing or pathologizing specific weights, promote practices and policies and personal behaviors that promote health that we know to be very helpful of stress management, sleep, physical activity for enjoyment, and eating behaviors. Eating for well-being, which really summarizes nicely an intuitive eating approach. They're not synonymous, but they work very well together. So we eat for hunger and satiety and to meet our nutrition needs, as well as for pleasure, and not eating for external factors of what my weight may or may not be. Respectful care, meaning that we recognize our biases and we work to continue to address our own biases and provide respectful care. And then life-enhancing movement. So how do we help our patients to move their bodies in a way that's joyful, that they is something that helps support stress management and helps to support energy levels and helps them to feel better overall versus getting on the treadmill to burn calories. So these are some of the core tenets of a health at every size approach. It should not be assumed that the health at every size approach says that everyone is healthy at every weight. Rather, the health at every size approach says that not everyone may be at a healthful weight. However, attempts to lose weight may increase harm more than the weight itself. And therefore, is the health at every size approach would suggest that weight loss is not appropriate. So there have been many studies to show that a weight-inclusive care can improve health outcomes. Here's just one example of a randomized control trial that compared a weight loss intervention group with a weight-inclusive approach that included intuitive eating as its nutrition intervention and address other lifestyle behaviors. And they found that the weight loss group did lose some weight, though the amount of weight loss was pretty nominal, but it was statistically significant. They found that the weight inclusive approach improved intuitive eating. They also improved their LDL cholesterol levels, saw decreases, and both groups saw increased intake of fruits and vegetables, increased physical activity and other healthful behaviors. So we know it can help to increase health-related behaviors. And then just some general strategies, sort of a starting point for how we can increase the weight inclusivity of the care that we're providing. The Harvard Implicit Weight Bias Test is a great starting point just to know what your own weight bias may be. I have all my students take it, and even students who feel very strongly that weight loss is not appropriate in some contexts, a lot of providers do find that they still have some weight bias, and so it's just helpful to know where we're at so we have a starting point. Recognizing the role of cognitive biases. So the fundamental attribution error says that we tend to over attribute individual personality factors for other individuals for their success or lack of success. So we might be more likely to say with our patients, they're not losing weight because they're not, they don't have enough self-control, they're not determined enough, they're not motivated enough, and then we underemphasize the role of other external factors, societal, environmental factors. And yet, interestingly enough, for ourselves, we actually tend to over-attribute external factors for when we're not being successful with something, and we under-attribute internal factors. Anchoring bias. So I think in healthcare, this is a really important bias to consider, because the anchoring bias says that the first information that we may have learned on a topic may emphasize or more play a greater role in our belief system, that initial piece of information. So for me, graduate school for nutrition, for physicians in med school, if some of the initial, information you learned about weight is that it's all about self-control and discipline and what, personal attributes, that anchoring bias is that information tends to influence us even many years later. Acknowledging our own privileges, even if it's not just privileges regarding some of the more overt privileges, but even thinking about privileges we don't always recognize, including weight status. And then increasing or continuing to focus on health-related behaviors, and then focusing on the patient's values. There are so many stories of patients who go to healthcare providers for an ear infection and they're told to lose weight. And it happens, and it sounds ridiculous, and it happens. And so, when our patients come to us, why are they coming to us? Are they coming to us because they're concerned, about this cough that they've had? Or are they coming to us because they want to lose weight? And so just asking them, how can we help them, and how can we keep the focus on what they're asking us to help them with? This comes from the American Diabetes Association, and is just a sample of weight normative language on the left column compared with more weight inclusive language on the right-hand column. So instead of saying eat less, move more, we might say, how do you feel about your eating behaviors now? How do you feel about your weight? Instead of saying, I think weight loss would be helpful for you, we could say something like, one of the things that we know is that weight can influence our outcomes when it comes to diabetes. Is this something you'd like to talk about? The patient may want to talk about it, they may not want to talk about it, and that's where we respect their wishes. But just some samples of language that we can use. Even just thinking about our physical spacing, I think the clinics here at the university have gotten certainly much better at how we provide more inclusive care. But even some of the details of thinking like what sort of artwork is being promoted in our clinic spaces. Does the artwork tend to promote more of the standard smaller body size individuals, or does it embrace body diversity? So thinking about our physical spaces. Having a weight inclusive network. So do we have other providers, dietitians, medical providers, therapists that we know that provide weight inclusive care and have that referral list? Some resources. And then finally, I just like this little cartoon here, and it says, every time I go on a diet, I lose my mind. Unfortunately, it doesn't weigh very much. So I think I'm out of time, but thank you for having me.
Important topic. Any burning question for Dr. Woodruff?
I have a question.
Yeah. So just shout it out.
Okay, I'll try to be brief. I'm a pregnancy doctor. Can you talk about gestational weight gain, which in my experience is universally frustrating and challenging, particularly because we have a set of recommendations, but folks just struggle to have any measure of control over it. So I've sort of moved to a style of mostly ignoring it and not really focusing on it. And so I don't know if that's right or wrong, though, and I'm curious to get thoughts.
Yeah, I mean, I'll speak, I talk about this with my students, and what I say is know your audience first and foremost. I think, there are going to be patients who are going to be obsessive about their weight gain during pregnancy. And so I had a physician here for all three of my pregnancies, and luckily she was just very gracious with, I gained a lot of weight in the first trimester, but then I didn't. And my overall weight gain was within the recommended weight gain. And if she had overemphasized in that first trimester, my rate of weight gain, it would have sent me into a panic earlier on, I think, in my life when I was younger. So know your audience. If it's someone who just you think doesn't have a lot of knowledge of healthy eating patterns, then I think just gently, if there's a trend, not just between visits, but over time, you're seeing a trend of unhelpful weight gain, you might say, is this something that you'd consider talking about a dietitian with? Because I know you care about the health of your baby. And so we can find ways to help you to eat in a way that might support the health of your baby as well. And so just recognizing what is their health literacy and what is their knowledge of nutrition. So for the people who already know, just being gentler, I think, on that. But it's tough. I don't know if that's helpful or not, but
thank you so much. Are Our next moderator is Dr. Michael Varner, who's a professor emeritus in the Department of Obstetrics and Gynecology.